Thank you. So after this very important deliberation by Purvi sir, that what the patients want to know, what are the expectation of the patients, it's important to understand what we can do as a oncologist and what are the options available to us and what precautions we need to take specifically for our older patients. So, treating lung cancer is now not so easy. We know there are so many choices. If you see patients with targetable mutations, negative patients, there are so many options. You will see choices ranging from immunotherapy alone to immuno plus chemo combination, and in chemotherapy combination also multiple of.
Have a good quality. Doesn't want to spend a lot of his left time in the hospital taking care of the toxicities part. So we decided to start immunotherapy after getting the NGS report. So this is how we need to make a balance between the toxicities, patient's expectations, caregivers' expectations. So it is not only about caregiver, not only about patient, not only about oncologist. It's a balance between all the three and coming to a consensus for each and every patient. So that is requires a lot of counseling, and when we do so in our busy OPDs, especially at academic centers which are already extremely overburdened, it is actually very difficult to bring about the points in a general OPD. That means in a OPD which is not specialized for our elderly patients. So that is why we try to take such patients where the choice is difficult for our geriatric OPDs, geriatric clinics. And in geriatric clinic, the good thing is that we have a multidisciplinary team and we can get the comments and the points from all our colleagues, the physiotherapy team, our dietitian team, besides our physicians and the doctors who will be managing the comorbidities. Because comorbidity and polypharmacy is very important part, I think that will be discussed in the subsequent presentations, that how we manage the comorbidities. That will also take a lot of difference in the choice of our treatments. Like the example of ribociclib, abemaciclib was shown by Purvi sir, we understand some specific toxicities are there with each every treatment, and how to select the treatment that is highly dependent on the toxicities which are expected. So that is the most important part, and the counseling part. Yes, every one of us knows that counseling is really important, but I know that every one of us will feel that there is a time lag, and when we are counseling, it is actually we are stressed for time. So what we have done in our OPD to take care of this, under the guidance of VK Mishra sir, we started to do multiple studies which are incorporating quality of life of the patients. So what happened with this, we tend to get much in-depth details about the patients, and also we attach the expectation chart, what is the expectation, because every academic center has significant waiting time before the patient can see the doctor. So that time can be utilized so that we can get the best possible information about the patients and can use it later to compare with the treatment outcomes. So if patient says that he is feeling better, scan is showing somewhat stable disease, that is also enough for a patient with advanced disease, and if it is matching with the expectation of the patient. So that is how we were able to manage the patient's expectation part and also the toxicities part, including the quality of life. Hopefully we'll be having multiple publications in the quality of life aspect for not only lung cancer, but for breast cancers and other cancers as well. So that is another part which we are doing. Besides that, we know that for management of lung cancer, it is highly dependent on multitude of tests. Every one of us knows the importance of NGS, PD-1 and other tests which we are already doing. But there is something lacking. So a patient of PD-1 80% and targetable mutation positive has a chance of 60% response to immunotherapy, 30 to 40% not responding to immunotherapy. So recently, I counseled a patient of close to PD-1 60 that there is a good chances of response to immunotherapy, but sadly after 4 cycles, the patient had progressive disease. the patient was not a candidate for combination chemotherapy, was started on single agent immunotherapy in the first line metastatic NSCLC. So there is something more beyond NGS, something more beyond PDL1 which we need to see and understand. And for that we now have some data already available. Microbiome composition is very, very important, and it dictates the responses to immunotherapy and various other treatments including chemotherapy. So how to study microbiome, what is the already available data, and how should we go about it? So the first step which we have taken is to do a microbiome study in our patients of non-small cell lung cancer. This study has thankfully got funding from ISCLC, so that we'll be able to do shotgun metagenomic sequencing on the stool sample for NSCLC patients who are planned to receive immunotherapy at the baseline and after 4 cycles of immunotherapy. So that is how we are expecting to know the microbiome. And you can see this was the initial short geriatric assessment tool data for older person with cancer. You can see in this study, and at which we do at TMH, is selecting patients of 60 years or more, though there are a lot of confusion whether should be 65 or 70. So I will not say anyone is wrong, whether it is 60, 65 or 70. It depends on the personal practice, the institutional practice, and some institutes take 65, some take cutoff 70, some take off 60. We take 60 because a lot of our patients above 60 have significant geriatric issues and they need to be managed like that. This was the initial experience of geriatric oncology clinic. This was published way back. Now, one important question: how common are geriatric patients? So, if we see the SIOG 2024
tagline this year, if you deal with patients with cancer, you are a geriatrician, because close to 50% of our patients are above age of 60 or 65 years. So this is really important. When we did we combined the data of multiple institutes and found that 33% of the patients at diagnosis of cancer are above the age of 65 years. And this data got to 40% for age above 60 years. So 40% of our patients above age of 60 years. That means a lot of our patients are fitting into the geriatric age group, and this is really important. We cannot neglect this. Till the time, few years back, we did not know so much about geriatric oncology, what is it and how it can help. But now we have enough literature from our own country. Multiple centers are now having geriatric, and Puri sir showed that there is an Asian Geriatric Oncology Society also now, which will be holding its first conference this year. So this is how, and it is expected that there is a significant aging in the population with the improvement in the various health related facilities in our country. As sir showed, it was initially life expectancy was 58 to 60 years. Now it has gone to 83 years or 80 years plus. So this is what we are expecting. Aging of population is imminent and it cannot be denied. It is a byproduct of the improved outcomes and improved health facilities. So if we see the proportion of patients with more than 65 years, more than 60 years in India, it is overall 56%. So it is a huge number. And if we see this hospital-based registry data, around 30% of the patients are more than 60 years old. This is, you can see the data. From July 18 to March 2022 at TMH, hospital-based registry, data was obtained by Banavali sir, 82,000 patients were registered. And of this, 24,000 patients, that is 30% patients registered at TMH Mumbai were more than 60 years of old. And of this, we could evaluate 251 patients, 1% in geriatric oncology clinic. So you can understand the differences and the need of widening the scope and improving the utilization of geriatric oncology clinic. That will require a large scale improvement in our infrastructure. If you see this data from TMH Varanasi, out of 33,000 patients which have been registered in TMH Varanasi, this is data around 1 year old actually. Now we have close to 70,000 registrations. 11,000 were more than 60 years. So 1/3 of the patients registered at Varanasi were also more than 60 years, which is stating that it is not only in urban cities and Mumbai, and Delhi, the patients are older. It is also in Varanasi and Tier 2 cities. So there have been multiple systematic reviews. I will just try to go to the part of geriatric oncology in treatment of lung cancer. So what we see as an oncologist when we are deciding the treatment for our patients and the selection of our patients, this includes multitude of the factors, including disease characteristics, performance status, geriatric assessment, apart from tumor burden. So this is our own data, which was published in the Medicine Journal, immune checkpoint inhibitors in patients with solid tumors and poor performance status. If you see this data, you will find around 46% of the patients who were having poor performance status and received immunotherapy were above the age of 60 years. So that again highlights the importance of assessment of the frailty and this various other factors relating to the poorer outcomes in patients with cancer. Just to summarize the data for various trials, these are some of the various trials, CheckMate 9LA regimen, CheckMate 227 regimen, which has shown that not so high, but some good proportion of the patients were from the geriatric age group. So if you see this data of CheckMate 9LA, which we discuss now, 719 patients, you can see close to 300 patients were 65 to 74 years of age and more than 75 were 70 years plus. What is immunosenescence? So immunosenescence, as we understand, with age, it is a phenomena in which there is a progressive remodeling of the immune function and it is leading to change in the innate and adaptive immunity. And it seems that there is a role of immunosenescence in enhancing the risk of severe immune-related adverse effects in older subjects, which is known as inflammaging. So inflammaging is a term which is concept which is now coming up, and it suggests that there might be some chances of increased immune-related adverse effects in patients with cancer. And this is suggested because of increased secretion of pro-inflammatory cytokines. However, there is a elders prospective trials which tells that 140 patients were included, age 70 was taken as a threshold. The immune-related adverse effects were not different between older and younger cohorts. So we saw that inflammaging data, that it seems that there is chances of increased immune-related adverse effects with treatment of immunotherapy in cancer, older patients with cancer. But till now, the data, including the prospective data, is not showing any increase in immune-related adverse effects. So that is a very important point, and that is an important question which we need to answer to our patients, whether I will be at risk of increased immune-related adverse effects, because these, with the increasing use of immunotherapy, the data is very important. Coming to some very important subset of neoadjuvant immunotherapy, this was a DREAM trial, and you can see this is a Keynote 6-7 study. So you see pembrolizumab with chemotherapy was utilized, PATH-CR was taken as important endpoint. What I want to highlight here, in all these trials, the median age is 63 and 64 years. So we cannot say that most of the trials are excluding patients of older age. For us, this is relevant. There is a general statement from various guidelines that most of the patients were not geriatric patients were not part of the trials. But if we see the recent trials, especially in non-small cell lung cancer, we can see that yes, at least median age is above 60 years. So that is can be utilized for our patients as well. So this is the data of importance of adding immunotherapy to chemotherapy as a neoadjuvant treatment. You can see the event-free survival, which is close to doubled, and it is also leading to some improvement in the overall survival. Some more mature data is about to come. And this is about the pathological response. If we are using pathological response as an important endpoint, you can see that only 11% patients with chemotherapy are having a complete major pathological response. It is increasing to 30% with this addition of immunotherapy. So immunotherapy addition has become a very important point even in patients with neoadjuvant treatment planned for curative adjuvant treatment. Similar is with NADIM2 data, and various adjuvant immunotherapy trials have also included patients with all the ages. So adjuvant chemotherapy in older patients in adjuvant chemotherapy trials, this is an important point. The patients of older age are not well represented in the trials. While in the recent trials, there is now a good amount of patients who are older. So that is the change. This is about the microbiome, which I was talking. But what is the importance of microbiome in terms of geriatrics? Because when we are dealing with geriatric oncology, this is a known phenomena that there is an aging associated decline in the microbiome diversity. So as we age, the diversity of the microbiome gets changed, and there is a decline in the microbiome diversity, and which is known to hamper immune related efficacy. There's a term called high firmicutes to bacteroids ratio, which is known to enhance the innate immune response, and it will lead to increased responses to IO. So this is a complex diagram which shows the benefit to IO and gut microbiota modulation. So gut microbiota modulation remains a very important aspect now, and that is becoming the focus of all the immunotherapy studies now. So this is a viewpoint which was recently published, precision targeting of gut microbiome for cancer immunotherapy. Here what we see, the patients were given 3 days of vancomycin to wash out the harmful bacteria, and they were then treated with SER401. This is a molecule which is known to increase the bacteroids amount in the gut. So what we are doing, we are modulating the microbiome composition in the gut to know whether it is leading to improvement in the outcomes. So just to summarize, this is the PDL1 percentage. Till now, we don't have any other biomarkers which are very well established. So PDL1 less than 50%, but fit patients, standard chemoimmunotherapy. Vulnerable patients, try to enroll in clinical trials. We have now multiple trials for lung cancers and GI cancers, where the patients are enrolled in go low study, go intermediate studies. If patient is frail, single agent immunotherapy with PDL1 more than 50% is an option, else you can utilize weekly chemotherapy regimens. So just final slide. Good performance status patients, they behave similarly to single agent immunotherapy as their younger counterparts, and overall toxicity seems to be similar. This importance of geriatric assessment and future direction needs to understand about immunosenescence and importance of microbiome in cancer. So multidisciplinary care and association with geriatric is the key, and with this I would like to stop here. Thank you for the patience listeners, and greetings from TMH Varanasi.
Thank you, Dr. Akhil, for such a wonderful talk. We can take some question answers. Any questions for Dr. Akhil from the audience?
Can I ask one question? Purvesh here.
Yes, sir.
Akhil, how are you doing the gut microbiome studies in the...
Yes, sir. So the importance of gut microbiome is that we need to test it by a mechanism which can understand not only the biodiversity, but also tells us the diversity which is prevalent in all our patients. So what we are doing is doing a shotgun metagenomic sequencing. So shotgun metagenomic sequencing by the Illumina platform has the advantage that it can tell about all the bacterial species which are prevalent in the gut. At the same time, we are comparing it with the patient caregiver. So we take this stool sample of patient caregiver also, because we understand that if a patient has developed cancer, his dietary intake pattern might have changed recently, and it might lead to changes in the gut microbiome of the patient. At the same time, we are trying to take the sample of our patient caregiver who is coming from the same family or close by.
So how is the stool sample process before it is put into the machine?
So it's important about the RNA isolation. So that is the part which is being done by our specialized lab, and the lab has been trained for that before starting this study. So it's a RNA isolation which is done most of the patients.
I think temperature and time are both vital.
Correct, sir.
Because RNA is, as you know, is very fragile.
Yes,
and
sir.
that's why I was asking the question.
Yes, sir. So it's very important to process the sample in correct time. That is why an in-house lab is required to at least process the sample. After the sample is processed, it can be easily transported to any other labs also. But first, the initial processing is mandatory to be done at the local place itself. So you cannot think that if you don't have a facility to process the sample in-house, it will be actually very difficult to do the test.
Thank you. Any other questions? No? Dr. Akhil had talked about a lot of interesting concepts in this. One was the microbiome, second is the immunosenescence, inflammaging. Any doubts regarding that? No. Okay, inflammaging is actually one of the old concepts in geriatrics itself, because in that basically there is inflammation also going on with aging. Inflammation is increasing with aging, and a lot of cytokines are released because of that. And the immunity, all the immune mechanisms, they go down. So that is the inflammaging, and aging is considered as a state of inflammation. So that was a very good concept that Dr. Akhil could bring up. So question to you, you had talked a lot about the immunotherapy. So I wanted to know that like regarding toxicities that you were talking about. So do you use, what are the various calculators that you're familiar with, and is there anything in particular that you're using?
So if we think about only immunotherapy, so there is already enough data from the prospective trials. If the patient is fit enough, there is no difference in the toxicities in between younger and older patients. In terms of chemotherapy, we are all utilizing CARG tool very frequently in our practice, and we have multiple studies, Cargo study and other studies running for multiple cancers at our institute and TMH Mumbai. But if we think about the immunotherapy related toxicities, I don't think there is a validated tool for highlighting the immune-related adverse effects for older patients specifically, because it is, if the patient is fit, his immune system, his or her immune system is likely to be working in a similar fashion. The only thing is that the difference is that some patients are responding while some are not responding. It seems to be related to microbiome and some other innate mechanisms which we do not know fully.
Okay.
That is my understanding. Anybody can add to it. Purvi sir, you would like to add to it?
Sorry, I was not paying attention here. Can you just repeat?
Yes, sir. Regarding the toxicity from immunotherapy in older patients, any specific comments regarding that, sir?
So, recently you were there in the Zoom meeting where we discussed about CDK4/6 inhibitors in breast cancer patients. And Ankur said that toxicity in our older patients is less than what is seen in the Western literature. And that could be related to some of our eating habits like yogurt and the difference between yogurt and curd. So curd is highly beneficial to microbiome, which you just talked about. So I think there are ways that our traditional ways of eating could actually benefit our patients as opposed to the Western population.
Completely agree, sir. So that is very important aspect. And it seems that microbiome diversity in our patients will be much more than the Western patients because of the eating habits which we have. And we eat less of processed food, while the Western people are in terms of eating more amount of processed food, which is a very important difference.
Okay, thank you. And, okay, Dr. Prem, any?
What are the most common side effects that you usually see, if any, when you do immunotherapy with older patients?
So, as I suggested in the previous data, there is elders prospective data also which suggested that if we are giving immunotherapy in a fit patient, he or she is going to behave in a similar way to a young patient. So it's about the immune activation of the patient. So the patients, what we see, raised thyroid function, so deranged TSH, that is a very common thing. And when we see that, we know that the immunotherapy is responding. So there are some immunotherapy related reverse effects which we are happy to see. One of that is raised TSH. other one is developing vitiligo. Some patients tend to develop white patches on the skin, and that is a good sign that immunotherapy is working. There is down regulation of the melanin pigment formation, and that is known to be associated with response to immunotherapy. So there are some of these adverse effects which are very important, and they are though they are called adverse effects, they are known to be related to good responses. So we are actually happy to see that because they are easily manageable. But when we see toxicities like pneumonitis, especially colitis, it is actually a difficult situation because that toxicity hampers the quality of life of the patients. So what we want to discuss is the quality of life. It is not about living longer with so many toxicities. It is about living longer with a good quality of life so the patient, an older patient, can enjoy his life with his or her life with the family. So I will not say that it is immunotherapy is leading to somewhat significant difference toxicities as compared to the younger, but there are many things which remain to be studied in our patients. And as I suggested, microbiome is really, really important to be understood, and we understand less than a 0.5% of that which needs to be understood for utilizing it indirectly in the clinical practice. We are also we have already designed a trial. Before this trial got designed, we have already designed a trial of utilizing Clostridium butyricum 588 strain. CBM 588 is known to be acting very well to enhance the immunotherapy response. And older patients are known to have dampened immunotherapy, immune-related mechanisms. So it is expected that older patients will have better improvement in the outcomes as compared to younger patients. So we'll have just designed a clinical trial for that also. So in one arm, the patients will be receiving placebo plus immunotherapy. In other arm, patients will be receiving CBM 588 along with immunotherapy, and we'll see. And there the patients will be stratified for the age. So we have taken a cutoff of 60. The patient will be stratified so that the equal number of patients of geriatric are there in both the subgroups. And all these patients will undergo the geriatric clinic evaluations who are above age of 60. So hopefully we'll get some more data from our own perspectives and our own departments so that we can understand it better.
Yeah, just a couple of more things. You said vitiligo is something you will be happy about, but what about the patient?
So it depends where the patient is developing vitiligo.
Yeah.
For example, if it is front on the face, it is actually sometimes patients are apprehensive and do not want it. So, but when we counsel the patient, that is a sign that immunotherapy is working. Most patients are able to adopt to it and understand, because that can be also masked by the makeups, especially for the females who are very apprehensive. So that can be masked easily. So anything which can be masked easily when the patient is going out can be taken care of. But if it is cannot be taken care of, for example, the patient is having colitis, the patient is requiring to go to washroom multiple times in the day, it is actually deteriorating for the quality of life. And so we explain this to the patient when we saw the first spot, that if the patient is, we have seen vitiligo on all the body parts, including the face, hands and legs, and whenever one spot is developing, it is likely that with continued immunotherapy, other spots will also appear.
Okay, and then you said you choose people who are fit for immunotherapy. So how do you decide their fitness for immunotherapy?
So it's just a geriatric clinic evaluation and
so
geriatric clinic
geriatric assessment.
Yeah, geriatric.
And then of course you mentioned about quality of life. Of course, it's a very old geriatric principle, which is of course very important, I think, in oncology.
It's not only for geriatric patients; it's for younger patients as well. Yes.
But it is a very well-established geriatric principle. I just have one question for Purvish, sir, if I can.
Yeah, sure.
So, I mean, one of the very important things which we always talk about, which we actually even highlighted in the webinar, I thought maybe we can sort of put it here, is shared decision making, which is very important, and goals of treatment. So sometimes shared decision making and goals of treatment might not meet. And of course, what happens when shared decision making does not happen, because a lot of times in our scenario, the patients do not even know about their diagnosis. So how do we sort of handle that conundrum? And of course, your experience on the same.
So first, Prem, I should thank you for being in charge of and running the monthly webinars so well for Asian Geriatric Oncology Society. Whenever there's a conflict in the shared decision making, it's very, very difficult to resolve that. And you have rightly pointed out that sometimes our societal problems are such that the caregiver doesn't want the patient to know that they have cancer. And I think they are only fooling themselves, because if they are coming to visit a center which is written as a cancer center or cancer hospital, they do know about it. And there's this secrecy between the patient and the caregiver increases the conflict or anxiety, and each one wants to fool the other person. So I think if we can resolve that by talking to them and explaining that the outcome will be better if they know rather than the other way around, it is good. Having said that, patient preferences and selection of treatment is not an easy thing. And I am hoping that with large language model, artificial intelligence, we will be able to ask the computer to do that task for us. That's the only thing I can say.
Thanks.
Just a couple of questions to Dr. Akhil. First of all, you have. I'll just ask one question, then I'll give it to you. So why do you use the CARG tool? Why not Crash? What is the difference between these two tools?
So if we see the CARG and Crash tool, it is about the easy utilization and easy when we are able to get a result. So Crash tool has its own problems that takes slightly higher amount of time in our practice, and CARG tool is validated, and as you are aware, we are doing multiple studies on CARG. We are trying to validate in for our patients. So actually, it is more about the experience. So when we started, the CARG was the most utilized tool. Crash came later, but it seems that Crash takes a slightly more amount of time. That is one point. Apart from this, when we are already utilizing one tool, we tend to develop experience and understands the pros and cons of that tool. So if we know even the cons of that tool, we will be able to adapt the tool's results in terms of utilization in the clinical practice. So what happens if you tend to utilize multiple tools, it will tend to confuse you more. So as a clinician, it becomes difficult how to utilize that data, how to utilize the result of that tool in the practice. So it is basically the experience and the very easy tools which are available. For example, we utilize OncoAssist app. The OncoAssist app, if you just click on it, you will get the results. And for the all types of, whether it is polychemotherapy or monochemotherapy, it is multi-agent or single agent, you get the results. So it's more about being easy to utilize and interpret the results for the practice. However, I do not cannot say that Crash is completely out of question. Crash can be utilized, but it's more about the protocols which we start to follow. And if we see that any data from our own setups comes that a Crash tool is better, definitely we can migrate to that. But I don't see that till now. If you have any experience and your points, you can definitely let us know.
No, I don't have data on Crash, but I know that Crash is better for hematological malignancies and it takes a bit more time than CARG tool.
Yeah.
But apart from that, how has been your experience with CARG, the CARG tool, and on immunotherapy patients and on hematological patients, have you been able to use it, or is it even applicable on them?
So when we are taking a decision for immunotherapy, it is not only about immunotherapy, because most of the situations as a clinician, we have to give immuno plus chemo combo in fit patients. So you saw the final conclusion slide. The patients who are PD-L1 less than 50%, fit patients will receive chemo plus IO combination. Okay. So it is not only IO. In 99% of the situation, ideally the approval is for chemo plus IO, not IO alone. So it is separate assessment for IO is usually not done.
So not used
in the routine.
Exclusively, you have not been able
Yes.
to use it on immunotherapy patients.
Yes.
So I know that you're doing a study on the CARG itself. So I just wanted to know, what are the common toxicities that you have seen in older patients, especially older adults? And secondly, if you have been able to apply that the CARG toxicity scores, how useful has it been? Have you been are you going according to the scorings?
So,
in the management?
so the CARG study is very useful and it will answer it prospectively. The good thing is that we were already utilizing CARG tool when we used to give a decision making, further decision making. For example, a patient has presented and has PS2, ECOG performance status 2. At the same time, albumin level is around 2.8. So in all the patients, when you are starting any treatment, systemic therapy, at least performance status and albumin should be noted. This is already which we were doing. Now, with the advantage of CARG, you can understand multiple other perspectives from the treatment of a geriatric patient as well, and can understand whether you need to be, you are able to give treatment in intensified phase or not. So CARG has actually helped us, and it has helped us to identify the toxicities like myelosuppression more, because in chemotherapy there are higher chances of getting myelosuppression. When using IO, there are higher chances of getting fatigue and other toxicities. Fatigue is a very important toxicity for all the systemic therapies which we utilize. So this is the experience. CARG helps, but if the investigator is blinded to results of CARG and uses his or her discretion to treat a patient without CARG results knowledge, that will tell us actually how much CARG has helped us to change the treatment. Because we already every one of us uses the other parameters like performance status, albumin and other points.
But my question was that, are you actually sticking to that calculator? Like if it says,
So
okay,
it's-
high toxicity, then are you, or intermediate toxicity, then
So
are
most
you
of the time,
going according to that?
yeah. So most of the time, the calculator results are matching with the perceived toxicity and the perceived frailty. So
Okay.
since we do the CFS from the clinical, the frailty score, which we see by seeing the patients and other questioning, the CFS is matching most of the time with the CARG tools.
Okay.
So CARG tool is useful, but how much it is adding to our clinical discretion, that we need to see through the study which we are doing.
Okay, and apart from the fatigue that you have mentioned, any other toxicities that you're seeing, especially in older adults compared to a younger person?
Definitely, myelosuppression is much more common. And if the patients developed thrombocytopenia, that tend to persist for a longer time. This is what we see in our patients. Most of our Indian vegetarian patients are B12 deficient. So B12 deficiency is a very important factor which leads to myelosuppression, and that is prolonged. Even after supplementation, it doesn't improve very quickly because it takes time to act.
Okay, okay.
So dietary evaluation, and we do anemia profiling and vitamin D in 100% of our patients who are getting started treatment, not only geriatric patient but also for younger patients.
Okay, okay.
I think we can take question panel discussion. We are
Roman sir, I think you already answered the question. I wanted to ask, in routine practice, which score you are using for deciding the geriatric assessment? And you already discussed about one trial that gut microbiome has a role in younger and older patients. So, do you mean that that microbiome has a direct role with imaging also?
Yeah,
microbiome has a direct role.
Yes. So what is happening in immune-related inflammations? With age, there is a low-grade inflammation which is persistent in the body, and it is likely to increase immune-related adverse effect. That was the concept which was thought. But with the prospective data sets, with the elder prospective data which I showed and our experience, we know that this doesn't happen in the routine practice. So that factor has, the factor related to immunoflagging is coming down in terms of immune-related adverse effects. But definitely, whatever treatment you provide, irrespective whether it is immunotherapy or chemotherapy, we know that the patients who are older behave differently and respond differently. So if they develop toxicities, it takes a longer time for them to recover, and also they take more amount of supportive care. So that is already we know. And it is now well established that the microbiota diversity is completely different in a young fit patient and older fit patients. So how that microbiota diversity establishment will help us to utilize treatment in like immunotherapy in older patients, that will be the key point, and how that will change our treatment. So as I told, we are already planned a trial of CBM 588 strain of Clostridium butyricum. So we always think that Clostridium butyricum is a harmful bacteria, but that specific 588 strain is known to be having a good immune stimulatory activity in the gut, and it is likely to improve the responses to immunotherapy. There is a, for your knowledge, there is a phase 2 RCT which was presented in ASCO 2023 for metastatic RCC, which doubled the responses to immunotherapy with nivolumab plus cabozantinib. So it is already being studied, and we are now trying to study in lung cancer, and in India there was no such a study. So concept of microbiome is rapidly evolving. We, as Purvi sir suggested, we do not know many things, how to handle it, how to transport the sample. There are so many aspects to that, and when we will analyze the data, hopefully we will be able to
at least contribute some 0.1% to the understanding of microbiome for our patients.
As far as microbiome is concerned, there is a commercially available pill off the shelf that can be used. But it's really the patient and caregiver. If the caregiver has a normal gut microbiome, that is very useful. And Shiv Sarin has shown that data in patients with end-stage liver disease, so alcohol cirrhosis of liver, end-stage liver disease. They have a 50% mortality in 1 year if they are not undergoing transplant. But with this caregiver's stool sample being put into the patient to normalize their gut microbiome, the mortality reduced by 90%. So it is a really important area, new area, relatively new area. The Gut Microbiome Annual Conference in the United States is now in its 10th year. So it is, a lot of people are working on it, but we are to also start working on it.